All right, guys, we'll make a start. So hopefully everybody can hear me and see the screen that I'm trying to share. Obviously, as part of this somewhat brief seminar, we're going to talk a little bit about lateral hip pain. So my name's Jay Ebert. I'm obviously based here at the HFRC Rehab Clinic. And this is an area that we're quite active in. We're doing quite a bit of work, certainly in the conservative treatment of patients with lateral hip pain. But also we see a lot of patients that do or may transition down the surgery pathway. And obviously there's a rehab component to that as well. So I'll get started. We don't have a whole lot of time, but certainly questions, more than open to questions. We might just hold those off toward the end of the short talk. All right, so what I'd like to cover really is part of this, and when we talk about lateral hip pain, the sort of more umbrella medical or scientific term is greater trochanteric pain syndrome, and it really refers to pain and pathology that originates on the outer part of the hip, and I'll come back to that. So I'd like to talk about what it is, or what is it, what causes it, and this is quite multifactorial for most people. What do patients report? And everybody's quite different in this respect. Sometimes it depends on exactly what is happening, what pathology may be causing their pain. It may depend on how they get around. It might be dependent on their strength and conditioning, but also their tolerance to pain. So we'll talk about that. I want to talk about some of the treatments, at least some of the more common ones that we do see, and then how exercise fits into that as well. And it is important to note that from an exercise perspective, irrespective of whether it is exercise as a sole treatment or exercise as an adjunct to any one of the other treatments, it really does play a pivotal role. All right, so firstly, lateral hip pain, it's common. It's going to affect about 25% of the general population. So we see it commonly. Often it's misdiagnosed, it's mismanaged. These are people that often report a quality of life and a level of disability that is actually worse than those people that are awaiting a hip replacement for end-stage hip arthritis. So it really is a debilitating condition, and it affects everything that people do, certainly in its latter stages. Now, what does it include? Firstly, bursitis. Now, what we have on the outside of the hip is a bursa. So a bursa is a fluid-filled sac. It almost sits on the outside of the trochanter, which is that little bony hump that you can feel on the outside of your hip. And the bursa is largely responsible for allowing some of the soft tissues and the tendons to glide nicely over the top. One of the big problems that we see is that for the vast majority of people with lateral hip pain, they have bursitis, but bursitis almost ends up being somewhat of a byproduct of other things that are going on. So a lot of these people are told they have bursitis, they're treated for bursitis, and that might include injections, which I'll talk about soon. And their pain continually comes back again and again because they're not being treated for what may be the underlying cause and what's driving that inflamed and angry bursa. But it is most certainly an important part of this condition. The second part, and certainly the more important part, is tendinopathy. So as you can see from the couple of pictures on screen, what you have particularly on the outside of the hip and through the gluteal is a couple of muscles deep in the bottom. The muscle comes down onto the outside of the hip and it's joined to that bony bump via tendons. So there are a couple of tendons around the outside of the hip that we see implicated most commonly, gluteus medius and gluteus minimus. Now what happens is where these tendons insert onto the bone, they become what's called tendinopathic, which is almost like a degree of degeneration in that tendon. So this is often something that occurs over a period of time. Rarely do we see it associated with a really traumatic incident like a fall. So this is a degenerative type process. But as we have seen, and now as we now know, gluteal tendinopathy is actually the most prevalent pathology in people that have pain on the outside of the hip. Further to that, people can have tears. Now, where the tendon inserts onto the bone, particularly in the latter stages of that very degenerative process, the tendon can tear. Now, these can be very small tears, they can be partial thickness tears, or they can be larger tears. It is important to note that there are lots of people getting around in the wider community that have tendinopathy and they have tears, but they don't have symptoms and they function really well day to day. So purely on the back of having these pathologies, this doesn't mean that people will get pain, and it also doesn't mean that the pain that they may develop can't be addressed, particularly in the presence of those tendon tears. For those that are symptomatic and for those that continue to be symptomatic and don't respond to conservative therapy, that's where we do see surgery in place. And I'll come back to that very briefly as well. And then finally, weakness. So weakness, somewhat of an imbalance in muscle strength around the hip and the pelvis, and a whole range of mechanical and movement issues that we do see. So it's important to note that for many of these, they actually become really important predisposing factors to people that develop lateral hip pain. But then people that get lateral hip pain, these are also things that progress further. So they're a really important part in that treatment algorithm. If we don't address these factors, even in the presence of something like an injection or even surgery, these are people that may be prone to continuing to have long-term problems, or they'll have recurrence of symptoms. So again, bottom line, treating the deficits mechanically is really important, and that's where exercise plays a really important role. Okay, so that's generally what is causing the pain. How do patients present? It's a real mixed bag. All of these patients are very different in the way they present, but it's quite common amongst women. So this is very much a female dominant condition, and there's a lot of different reasons for that. One of those is that women naturally have a wider pelvis in preparation for or after childbirth. You know, those tendons have to stretch a bit more, they're loaded very differently. Women are just naturally built in a different way to men. So for that reason, there is a higher incidence of symptomatic lateral hip pain in women, particularly over the age of 40 or 50 years. We also see, irrespective of whether it's men or women, that they generally are a bit heavier. So they often have a higher body mass index, and you've got to keep in mind, it's much like a symptomatic arthritic hip or arthritic knee. The more weight that we bear, the more load those tendons and joints have to bear. There's often an absence of a traumatic event, and that's what's most frustrating about this condition. Most of the people we see, they haven't had a fall, they haven't had a significant trauma, they may have been active in the past, they may not have been active in the past. But for many of these people, they wake up, they get a bit of an onset of mild symptoms, it comes and goes, it progressively gets worse, but there's no definitive reason for why that pain has come in the first place. And that's quite common amongst these people. Where they have pain, so they often have pain on the outer part of the hip, so particularly around the trochanter. This, of course, is where that bursa sits, and it's where those tendons insert into. They can get pain in the buttock, and that's quite commonly reported as well. And they also get pain that radiates right down the outer part of the thigh. And we get a lot of patients, particularly those that have more significant tendinopathy or tears, where that pain can radiate down to and even beyond the knee. Again, one of the big things with this is that when patients are given this label of bursitis and injections don't work and their condition worsens and they're getting that radiating pain, they're often told that it's probably coming from their lower back. And they'll go through all of these investigations to look at their back and look at whether there's some sort of neural or nerve component, when that pattern of referred pain is very consistent with gluteal tendon problems. They don't have a lot of groin pain. In fact, they don't have any groin pain. Now, what we know is that pain on the outside of the hip is very much linked to pathology on the outside of the hip. If patients have a lot more pain through the front of the hip and down through the inner thigh or the groin, that tends to be very much linked with issues inside the hip joint. So people that have end-stage hip arthritis, they'll get a lot of that pain inside their groin. Patients can still have that, but it would probably suggest that yes, they've got some pathology on the outside of the hip, but they've also got some issues within the hip joint. So this becomes a really important differentiating factor between what is lateral hip pain and what is intra-articular hip joint pain. Other problems people have, standing. So standing for long periods. Obviously, if you stand for longer periods, you bear a lot more load through the tendons, and it also compresses and squeezes that bursa. So if they are pathologically painful, people get more pain. Getting up from a chair, and we often find that people that have been sitting for longer periods, they have more discomfort when they get up and they start moving. Going upstairs, interestingly, is often more of a problem than going downstairs. So when we go upstairs or up slopes, there is a lot more gluteal or buttock involvement, and these people tend to have more pain. People that are going downstairs, often that's more problematic for people that have more knee symptoms as opposed to hip symptoms. Lying on the side. Now, it stands to reason that if we lie on that painful pathology, people get pain. But it's quite interesting that when people start to lie on the opposite side, that can also be a real problem. So all of a sudden, sleeping becomes a real issue for these people. And the reason for the pain when they lie on the opposite side is what happens here is when people lie on their non-symptomatic side, let's say they're sleeping at night, often they'll tend to turn over with the other leg. And what that does is it creates a lot of tension on the outside of the hip. So we'll talk about ways to try and mitigate that soon. But for the most part, sleeping becomes a real issue. And that's largely why sitting cross-legged becomes a problem. Because as soon as we have to take the leg across the midline, that becomes a very provocative position. They'll often be weak. They'll often have pain, particularly when they try to push the leg out to the side, because that movement loads gluteus medius and gluteus minimus. Movement around the hip is often unaffected. We've got to keep in mind that these are patients that don't have hip arthritis. So in theory, their hip joint is more than happy to move. But of course, what happens in this condition is as soon as we work into extremes of motion, that creates more tension on the outside of the hip, and then that can become quite painful. We also see some mechanical-based issues, and one of those is a positive Ellenberg. Now, I'm not sure if my video is going to work overly well, so I'll do my best to demonstrate. But what happens here is when we stand on one leg, those tendons have to work really hard to support the pelvis. Now, if the tendons that support the pelvis are dysfunctional, if they're not doing what they're meant to be doing, these are patients that have that drop of the other hip. So this is what we do see quite commonly. These need to be strong enough to keep that hip up. And naturally what happens is when people don't have that control, when they don't have that muscular function, either with or without pain, they limp, they compensate, and they'll throw their body over that affected side. So that is quite common. All right, treatments. So a whole array of treatments that are getting around, and I'll start with the basics. So good education. You know, patients don't really understand their condition, so they need to understand what it's all about, what is primarily driving their pain, and even simple things that they can adopt day to day to reduce their pain and better manage their condition. And this is where we're talking about how to stand, how to sit, how to change their sleeping positions so they can unload that part of their hip. So they're simple things, but they're simple things that add provocative load. So if we can modify those, we can make a really big difference in many people to reducing their day-to-day pain and improving their sleep. Better managing coexistent issues. Now, it could be musculoskeletal. These are patients that may be a little bit heavier, they might be a little bit more unhealthy, so addressing their low back issues, their arthritic knee problems, making sure they're eating well, making sure we're looking at ways of maybe improving their activity through non-painful means to better control their body weight. And they're not always easy, but these are things that go a long way to reducing pain, and the evidence does strongly support that. Injections. I've mentioned injections already. The most common injection we see is a corticosteroid. It's a cortisone injection that is into that inflamed bursa. Now, if bursitis is the primary driver of that, but we need to remember that the bursitis itself is often caused by something else. So we need to make sure that even if they get some good pain relief, we are addressing all of the other issues that have brought about that bursitis in the first place. So cortisone is one used very commonly. We see a whole range of other injections, and I'm not going to go into these in any detail, but these are injections that are slowly building and encouraging evidence base, but they are still in their relative infancy. So these are things like PRP. So platelet-rich plasma is essentially somewhat of a blood injection, and tenocyte therapy. So these are injections into the tendon. These are into the diseased tendon, whereas cortisone is into the bursa. It is not designed to try and address the tendon-based problems. Shockwave therapy. Now, this is a non-invasive physiotherapy modality. This is something that we do see employed here at the clinic. It's an adjunct to exercise. But the way that shockwave therapy works is, firstly, it's designed to have somewhat of an analgesic benefit. It helps with pain, but it also looks to kickstart an intrinsic tendon-based healing process. Again, I'll reiterate, this is a therapy that is used in combination with exercise. And we often find that for many of these patients, it's not just one modality that does the job, unless it's exercise. It's exercise combined with another modality or modalities. Surgery. So we see lots of patients that are going down the path of what ends up being a surgical reconstruction of that torn tendon. For anyone out there that has had a rotator cuff repair in the shoulder, this is that surgery, but it is done in the hip instead of in the shoulder. So it's a tendon-based repair where they bring the tendon back to bone and anchor it on. It's a big surgery, it's a last resort, and this is for people that are not responding in the right way to conservative therapies, and they do have sizable tendon tears. And then, of course, exercise. Now, exercise on its own, we have found to be a very good treatment. And again, there's very good evidence for that. But exercise as an adjunct to any one of those other treatments is also imperative. So what I'm going to do now, just over the last bit of time that we have, is talk about how we may use exercise to address pain and symptoms and mechanical deficits in these patients. Now, exercise, again, is multifactorial. I think we can all appreciate there's so many different exercises that are getting around, and particularly for this condition, what works for one person won't always work for the next person. So it's really a case of finding the right set of things that can be progressed over time that works for that patient and their specific condition. So what you can see here are really a few lower demand activities, and these are often really great for kickstarting that early process. When we say isometric exercises, we're talking about exercises that load the muscle and load the tendons without movement. So there's no lengthening and contraction of the muscle, and there's no movement of the joint itself. So one of these that we often quite like relatively early on is the one that you see down the bottom left. Now, this is a really simple bridge, but it has the addition of a band. So the rubber bands, different strengths, different intensities, these are a great mode of exercise for people with lateral hip pain. So the way this may work in this particular exercise is the band is tied around the knee. This is a bridge, but the idea here is to be in the bridge position and hold the knees apart against the load on that band. So already we're working a lot harder through those gluteal muscles. That in itself is an isometric exercise that creates the early load that we want. And then of course, there's always scope to add something like a bridge to that. So again, they're early stage things. They're designed to wake a few areas up, improve some early muscular support. The other benefit that we have seen, and there is a real growing evidence base around this, is that isometric exercises, and we're talking about sub-maximal isometric exercises, they have been shown to exhibit an analgesic effect. So we use these exercises to improve strength and control, and then there's an added bonus of these types of exercises actually alleviating pain, at least for a short period. So that's an added bonus of some of these early stage activities. But of course, there needs to be a move toward a whole array of exercises that load the hip abductors, load the muscles that take the leg out from the side in both non-weight bearing positions and weight bearing positions. So the whole underlying premise here is firstly to load those pathological tendons, and that is important for those tendons to heal. But obviously there's also a role of improving strength, improving functional support, so that we don't fall into those provocative positions as well. Again, there's a few different examples here. There are a lot more than this, and of course it's really trying to find options that work for that patient based on how they present.
And then, of course, there needs to be a progression toward activities that load the hips and the pelvis in a more functional way. So these are very patient-specific and patient-dependent. This is where things like the bands can work quite well, but they need to be exercises that load a patient in a weight-bearing way that is relative to the types of activities and tasks that they need to return to. So again, I'll reiterate, this is really quite varied and very different from one person to the next, but it certainly needs to be engaged in as part of these rehab-based activities. So just to wrap up, thanks all for listening in. My contact email is there if there are any queries. So by all means, I encourage emails. Most certainly would love to catch up in the clinic. So if you certainly want to engage in something that's a little bit more specific to you, please call in at the clinic. A time can be arranged, and it would be great to start moving forward. Thanks very much.